Hi everybody, I just wanted to apologize again for not giving you a little bit sooner notice about changing to the video format versus having a lecture today based on the weather. I was trying to do the best thing for everybody. It ended up that it wasn't so bad downtown, although I'm looking outside. I just got home and looking outside and it's looking like it's snowing quite a bit harder. So anyway, my intention was to do the right thing. Maybe I did, maybe I didn't, and I apologize if that was inconvenient for you. That said, I wanted to go over a few things on that fluid and electrolyte acids and bases lecture that we're going to do today, and that you'll be tested on this week in addition to last week's lecture. So taking a look really quickly at that, don't forget, if you go to media links in content, go to content, media links, and then you'll see the videos. You'll see electrolytes, acids and bases 1 and 2. That covers this a little bit more in detail, but I'm going to highlight a few things. On that first slide, distribution of water, body fluids, take a look at that and make sure that you have a good understanding of that and definitions, etc. I think I did an okay job of explaining that in the video previously. And regarding pediatrics and aging, I just wanted to highlight there that pediatrics have a real high percentage of water in their body, so they're real susceptible to changes. And then preterm babies even higher, so really imperative that their fluid level is monitored. That's why fever is such a big issue for babies, for little kids. They dehydrate very, very quickly and can head downhill, whereas some of us wouldn't think of dehydration as that big a deal. You know, if you're thirsty, respond to it. Kids don't drink water, they don't feel good, they get a fever, and if you're not paying attention, they can decompensate really easily. The same way, elderly people decrease fluid and renal decline, other issues with that. And then also just mentioning that obese people are easily susceptible to dehydration because of the high body fat. The next major issue that you really do need to understand is the net filtration, forces favoring filtration versus forces favoring reabsorption. Make sure you understand the difference between hydrostatic and oncotic pressure. Hydrostatic pressure is a pushing pressure. And it's really important when we talk about this to understand, where are we? Are we in the blood vessel? Are we outside of the blood vessel? Where in the interstitial space? Where are we? Because that's going to determine what we're talking about here. So when we talk about capillary hydrostatic pressure, that's the pressure inside, the pushing pressure inside the blood vessel, pushing out, trying to get out, pushing against that wall, trying to get out. Whereas interstitial hydrostatic pressure is pressure inside the interstitium, in the connective tissue, the area surrounding the blood vessels, for example, and that's pushing as well. That's a pushing pressure against the vessels and against the tissues. So that's what hydrostatic pressure is. Oncotic pressure is a pulling pressure. So if you're inside, if you're in the capillaries, there's something that's holding that fluid in. At the same, and it's usually the contents of the blood, which is holding that in, mostly determined by proteins such as albumin, which is a protein in the blood, but also there's immunoglobulins. There's a lot of things in the blood that hold on to it. So that's plasma oncotic pressure, and then interstitial oncotic pressure is what's in the interstitium that's going to pull on the water and try to keep the water there. So you have all these forces at play, and that's going to determine from one period of time to the next what's going to happen with the water. Is the water going to stay in the blood? Is the water going to leak out? And when it does leak out, it leaks into the interstitium and swells up. We call that edema, and that's what's the next really important concept. On that slide on edema, make sure that you understand that and there's an increase in the forces moving fluid into the interstitium, usually inflammation, which makes the capillaries permeable. We'll talk about that next week, but when the capillaries are permeable, the water leaks out and goes into the interstitium, and therefore you get swelling. So when you get a mosquito bite, for example, you get an inflammation, and fluid leaks out of the blood vessels into the interstitium, and you get a little wheal or a little round swelling there, as with any injury or inflammatory response. And there's a decrease in the forces of moving fluid away from the interstitial space. So the net response is more fluid in the interstitium, and therefore edema. Regarding so the causes, an increase in the capillary hydrostatic pressure. If there's some reason inside the capillary that the pressure increases, like high blood pressure, you're going to be pushing against the walls, and it's going to cause more of a leakage out into the tissue. Could be an increase in extracellular volume. You might have an increase in sodium. Person's having a high sodium diet, and therefore there's more water in the blood. As a result, there's an increase in the capillary hydrostatic pressure, wanting to push out against the walls of the capillary of the vessels, and therefore leaking out into edema. So people with high blood pressure likely to have edema in certain parts of the body, or could. Or an inflammatory response would increase the capillary hydrostatic pressure and trigger an increase in edema. There's some other things listed as well. Sodium retention, as I just mentioned, high blood pressure, tight clothing can do that. That can increase capillary hydrostatic pressure. Prolonged standing. So if you're standing for a long period of time, that blood is not going to be returning back to the heart. It's going to kind of pool down the lower extremities, and that's going to push on and cause edema. So people who stand, like a hairdresser or somebody who's a factory worker who's standing in the same place all day long, they're going to have an increased risk for venous congestion and edema. Decrease in plasma oncotic pressure. So this is a situation in which you have a decrease in the stuff that's pulling on the water. So a decrease in albumin, which happens with liver disease. Albumin is produced in the liver. If you have a loss of that albumin, you have a significant decrease in the oncotic pressure, the holding on pressure in the capillary, and the fluid is going to leak out. So people with liver disease have those big distended abdomens that are mostly water. It's not fat. It's you can see that they're not fat. There's just an excess water. Kidney disease, as I mentioned here, can also, if there's excess excretion of albumin, your body's letting go of the albumin. In a nephrotic syndrome, you don't know what that is yet, but we will talk about that later in the semester. If you're losing albumin, you're losing oncotic pressure, you're going to get edema. An increase in the capillary permeability, as I talked about earlier, there's more, the vessels are going to be permeable and the water is going to leak out. That happens in inflammation. We haven't talked about it. We will next week. And then lymph obstruction, I'll let you read about that. Okay, so that next slide is a kind of a scheme, the red and blue scheme. Take a look at that. That's really important so that you understand. If you do not understand edema, well, there'll be a number of test questions, but more than that, it's going to happen. It's going to show up again and again as we go throughout the semester. So it's important that you understand that now. Regarding water balance, so ADH, antidiuretic hormone. So it's an anti-diuresis. If diuresis is something that keeps which filters the blood, antidiuresis is going to be holding on to. So you're going to be holding on to. So ADH is the water hormone. It controls the amount of urine that's excreted. It's produced in the hypothalamus. In response to the osmoreceptors throughout the body. There's these pressure receptors that say, hey, we need that, the pressure is a little bit low, we need more, so secrete ADH. It holds on to the water from being excreted in the kidneys, and therefore you have an increase in the reabsorption of water, and increase in the plasma fluid, and a decrease in the concentration. So if you increase the fluid, you have more water, it's going to be more dilute, and therefore you're going to have a decreased concentration. I explain that like that because it's important to understand concentration, concentration where, dilution, what's happening. I hope that makes sense to you. All right, the next concept there is sodium and chloride. There's nothing difficult about that, but make sure that you do understand. Sodium is extremely important, so read that in your book so that you really understand. The following slide there talks about kidneys excrete sodium, thus regulating plasma concentration. It's regulated by aldosterone. So ADH, antidiuretic hormone, is the water hormone. Aldosterone is the sodium hormone, which ultimately affects water because water follows sodium. But aldosterone, which increases the reabsorption or the holding on of the sodium. So if you increase your aldosterone, you increase sodium reabsorption, you increase water that's being held on, and it's going to increase blood volume, blood pressure. And then the opposite happens. Aldosterone does the opposite for potassium. Sodium and potassium work oppositely there. And so that what aldosterone does is it causes the distal tubules to release potassium in the kidney and therefore dump potassium. This becomes important in the next section, in the section on acids and bases. And also when we talk about hyper and hypokalemia, natremia, etc. Make sure that you understand renin and its role, that when you have a decrease in blood volume, let's say you're bleeding, when your body perceives a decrease in that volume, you get an increase in renin released in the kidney, and renin converts angiotensin 1 to angiotensin 2, actually renin increases the release of angiotensin 1, which angiotensin converting enzyme actually will cause the conversion to angiotensin 2. Angiotensin 2 will trigger the release of aldosterone. So some of you have heard of ACE inhibitors. ACE inhibitors are a class of drugs which inhibit angiotensin converting enzyme from converting angiotensin 1 to angiotensin 2, and therefore preventing the release of aldosterone. Aldosterone holds on to sodium, which holds on to water, so therefore it is a blood pressure medication which decreases blood pressure. If you don't understand what I just said, review it and look at it in the book. All right. More about that, natriuretic hormones, take a look at that, not spend a lot of time with that. Isotonic solutions, that's important. So an isotonic solution is a solution that has the same concentration as the blood. And so when you are trying to hydrate someone, if you just give them water, you're actually going to dilute their blood. What you really need to do is make sure that you are giving an isotonic solution that has electrolytes in it. An isotonic fluid loss, so that's going to be like blood loss. If you lose blood, you're going to have an isotonic fluid loss, or just in some way, in a urine, perhaps urine loss. All that is going to contribute to an isotonic fluid loss. An isotonic fluid excess, generally it's as a result of administering too much IV fluids, isotonic IV fluids with electrolytes. Okay, now the next section, again, really important. That's the hypertonic alteration. So what would cause you to have an increase in concentration? A hypernatremia would cause that. So an excess in sodium will cause that hypertonic situation. So that would be either a water deficit. So you either have a decrease in water, an increase, which causes a relative increase in sodium, or a hyperosmotic condition where you have an increase in the concentration in some way. The problem with this, let me just back up here. So, the problem with this is that when you are hypernatremic, too much sodium that holds onto water, you have, and so water will move from the intracellular compartments to the extracellular compartments, and therefore the problem with a hypernatremic situation is the cells themselves get dehydrated, and they will actually shrink because the water moves from the cells into the extracellular space. If you're not sure exactly where extracellular fluid volume is, go back to page 1, like the second or third slide, and make sure you understand that. What would cause that? Excess IV bicarbonate. So if for some reason you are giving intravenous fluids and you have too much bicarbonate, sodium bicarbonate, that's going to cause an increase in sodium, and that's going to cause a hypernatremia. An increase in aldosterone release. Something in the body is telling the body to release more aldosterone. Cushing's condition, Cushing's syndrome or Cushing's disease, which causes an action on the adrenals such that you increase aldosterone. That's going to hold on to sodium and increase the blood pressure. And so that's a hypernatremic situation. And then one other thing is licorice. Licorice causes an increase. I'm not talking about red vines. I'm talking about black licorice, licorice tea, licorice root extract, something like that, causes increased release of aldosterone and will cause an increase in blood pressure, especially with people who already have high blood pressure. For people with normal blood pressure, young people, it's not going to be as much of an issue. Let's see, what else? And then water loss. If you have normal sodium, but you have a decrease in water as a result of fever, diabetes, we haven't talked about that, but there's a lot of thirst because of all that sugar content, so that's going to cause a dilution. Sweating, diarrhea, so any acute disease. Remember when I talked about how babies or young children are susceptible to fluid changes? Well, fever, sweating, diarrhea, vomiting, any of those things are going to cause fluid loss, and therefore you're going to get a hypernatremic condition. The manifestation, look right there. So the cells, as I mentioned earlier, are going to dehydrate. When that happens, you actually hypopolarize. Remember when we talked about, well, we haven't talked about it. In anatomy and physiology, you might have to go back to this. when you have the membrane potential across the membrane, the electrical charge across the membrane, it needs to be a certain polarization. There needs to be a separation between the positive and the negative charges, and that needs to be within a certain range. If you are losing sodium from the inside of the cell and more of the sodium is going to the outside of the cell, so you have a hypernatremia, excess sodium in the blood, what's going to happen is you're going to hypopolarize. So it makes for a real, when it's hypopolarized, it's going to easily cause a firing of the membrane potential, the action potential, sorry, and therefore you're going to have hyperactive muscles, hyperactive reflexes. So an increase in the reflexes, convulsions, pulmonary edema, that's not directly the same issue here, but that's another issue. I'll maybe mention that in a minute here. Let's see, tachycardia. So you're going to have all kinds of neurologic symptoms. You're going to be firing membrane potentials really quickly, and so everything is more active. So that's, potentially that heart is going to be contracting too fast, getting out of rhythm, and you could have a cardiac arrest. All right, water deficit. I think that those are pretty well self-explained. I'll let you look at that on your own, and then making sure that you look at chloride. Remember that the chloride isn't so much an issue, but it responds to it. Sodium is often chloride often follows sodium because they have the same, sodium is a +1 and chloride is a -1, so they're electrically charged, balanced. And so a hyperchloremic condition can happen when there's too much sodium or too little bicarb, because bicarb is a negative charge, and so if there is not enough bicarb, your body holds on to chloride to maintain that negative charge. Read about that if you're not clear about that. Let's see. So severe hydration can cause hyperchloremia. Kidney failure caused by a loss of bicarb could cause a hyperchloremic condition, and brain injuries can also cause a hyperchloremic condition. Let's see. Okay, so hypotonic alterations. So in a hypotonic, you have a decrease in the concentration. You have less concentrated, which would mean that either you have too much fluid or a decrease in the sodium concentration. Let's talk first about hyponatremia. Hyponatremia would cause a situation of a hyperpolarization. So you have less sodium in the blood, more sodium in the cells, and therefore that membrane, the gap between the positive and negative charges is even greater, and therefore it takes more of an action potential, a higher action potential, to actually cause contraction of that nerve or muscle cell, and therefore everything is a little bit more sluggish. If you look down there at manifestations, you're going to have neurologic changes such as lethargy, confusion, decreased reflexes, and you could have seizures as a result of lack of ability to charge. It actually causes a disruption. It's maybe not as intuitive there, but the bottom line is you're not getting as much of a reflex, you're not getting as much of a response. Let's see. Caused by what would cause a loss of sodium? Vomiting would. Um, Vomiting, diarrhea, diuretics. Those are all there in the notes. Or excess free water intake could cause a hypotonic or hyponatremic situation. Hypertonic hyponatremia. So in this condition, it's a hypertonic condition. So it's an increase in concentration, but it's not sodium's fault. It's a hyponatremia. It means that there's something else. Either it's protein, lipids, or sugar, hyperglycemia, which can displace sodium. And so it's a hypertonic situation, meaning it's greater concentration, however, not as a result of sodium. So as a result of excess protein, excess fat, or excess sugar. All of those, so sugar, for example, that would be an example in a diabetic condition where the glucose will actually hold on to the water. The glucose is a large molecule, and so it attracts water. You can take a look at that in your book as well. Water excess would cause the same thing, so compulsive, that would cause going back to, it wouldn't cause the hypertonic hyponatremia, it would cause the hyponatremia. So if you drink too much water, you would get a hyponatremic condition. If you had a kidney disease where you're not concentrating your urine and you're just losing just pure water, you're not losing concentrated salts, that would lead to a hyponatremic condition. Cirrhosis or any kind of liver disease, as we talked about earlier, can cause a water excess because you actually have there's a lack of excretion of water. There's because of the oncotic changes. And then SIADH, we won't talk about that so much now as we'll talk about that when we get to a later section of the book. But basically, it's SIADH is syndrome of inappropriate ADH. So that means there's too much ADH. Generally, that's a result of ADH being secreted by a cancer cell. Some cancer cell that randomly produces ADH. ADH, antidiuretic hormone, it holds onto water. It doesn't allow for the kidneys to excrete water, and therefore you have a relative water excess. As a result, neurologic symptoms, cerebral edema, muscle twitching, etc. So you can take a look at that. Hypochloremia. Hypochloremia, what would cause you to lose chloride? An easy one is vomiting, because what are we vomiting? We're vomiting hydrochloric acid from the stomach. And so that would cause a loss of chloride. Or an excess in bicarb that would cause an excess of bicarb, because bicarb is a negative charge. Your body is going to want to decrease. If you're holding on to bicarb, you're going to get rid of the chloride because you've got to maintain that electroneutrality, and so you want to keep the same amount of negative charge. So if you're holding on to bicarb, which is a negative charge, then you're going to have to get rid of chloride, which is a negative charge. This happens in cystic fibrosis. Cystic fibrosis. The issue with cystic fibrosis is chloride. There is a decrease in chloride secretion and an increase in sodium secretion. What that makes is a very thick mucus, And so people with cystic fibrosis have problems in their lungs because they get very, very thick mucus in their lungs, or very, very thick mucus in the pancreas, causing obstructions. We'll talk about that later in the semester. But it's an issue with a loss of chloride secretion, which thins that mucus. Potassium. Potassium is another major intracellular cation, where sodium is the extracellular cation. We want the highest concentration of potassium is inside the cell. It's important for maintaining the sodium-potassium pump, and it maintains that electric neutrality in relationship to sodium and hydrogen. This is going to be really important here. So when you have a loss of potassium, decrease in potassium, you have a decrease in repolarization, and therefore a change in neurologic or muscular activity, because you're not able to repolarize, you're not able to get back to that polarized state very easily, and you can easily go into, it can fire again too quickly and cause issues. All right, next slide, the last slide on page 4, their potassium levels. Changes in pH affect potassium balance. This is extremely important. In a condition of acidosis, which we haven't gone over, but we're going to soon, in a condition of an acidosis, the hydrogen ions accumulate in the intracellular fluid. So your cells hold on to or gain hydrogen. As a result, in order to maintain the electrical neutrality, your body has to get rid of a +1 ion. So if it's producing more hydrogen ion as a result of an acidosis, your body has to get rid of a +1 ion. It gets rid of potassium. So your cells dump potassium in a condition of acidosis, such that potassium leaves and goes out into the blood. Causing a hyperkalemia. You get excess potassium in the blood. If you read there under acidosis, it says decrease intracellular fluid, potassium, causes a decreased potassium secretion by the distal tubules. So your distal tubules are not going to be secreting potassium, and you're going to actually get an increase in potassium in the blood. And that's going to cause problems, which we'll talk about. And in an alkalotic situation, in a situation where you have an increase in the pH, in alkalosis, the intracellular fluid hydrogen ion is decreased. So your cells are going to they're going to have a loss of hydrogen ion. And so what you're going to do is, actually going to hold, the cells are going to try to hold on to more potassium. And as a result, you're going to get hypokalemic. You're going to have a loss of potassium in the blood. No, I realize I'm going through this stuff extremely fast. If this isn't second nature to you and you don't understand it, you've got to go back to the book and read, and or get on a website. Use the book resources on Evolve, Elsevier, whatever, to try to understand this a little bit better. And then remember, aldosterone affects potassium as well. It increases the plasma potassium and causes increase. an increase in aldosterone causes a decrease in potassium, and therefore you're going to lose potassium. You're going to get a hypokalemic condition when there's excess aldosterone released. All right. I think that's it. That's most of that. Read about hypokalemia and hyperkalemia. Remember, in a hypokalemic situation, you have a loss of potassium in the blood. This would be as a result of an alkalosis, such that your body's going to hold on to more potassium. You're going to have membrane hyperpolarization, and that's going to cause a decrease in the ability to cause an action potential, and so the skeletal muscle, the muscle is going to be sort of flaccid, weak, not going to be doing as much. The issue is in the heart. If that happens, you're not going to get the kind of contractions that you need, and therefore you're going to it's going to be problematic. You're going to have dysrhythmia and cardiac arrest. You're not getting blood to where it needs to go. Okay. A hyperkalemic condition, so excess potassium in the blood, is going to cause a hypopolarization. I always have to remind myself this is hard. You can go from one thing to the next really quickly, and you have to kind of think about what's happening. It's not second nature to any of us. The hyperkalemia is rare because the kidneys, they'll perceive that there's too much potassium, and they'll start dumping it. In hyperkalemia, remember, happens in a situation of an acidosis, where your body has, where your cells have an increase in hydrogen ion, therefore they dump potassium, and your body gets rid of potassium. Well, your kidneys will compensate and go, oh, okay, this is too much. But if you don't have a healthy kidney, this could become an issue. Again, in a hypopolarized condition, you don't have as much of a gap. It doesn't take much much of a polarization to cause a discharge, and therefore cramping, restlessness, rapid repolarization, and therefore increase for cardiac arrest, secondary to beating out of control. All right. Calcium and phosphorus, remember that they're opposite. They work oppositely. There's nothing really difficult about those. I think you can read those and do pretty well. So I'm going to have you do that. Look at hypocalcemia and hypercalcemia, what happens. And remember where we're talking about. So emia means in the blood. So hypercalcemia would be excess calcium in the blood. Hypocalcemia, not enough calcium in the blood. It's probably in the bones. It's being stored there. It's not being released. In the hypercalcemia, for some reason, the bones are letting go, or there's some reason why there's a large amount of calcium in the blood, and that's problematic. Causes a decrease in excitability, and therefore you have that atonic condition where the heart's not really wanting to contract. The muscles are weak. Everything is slowed down. Kidney stones. Why kidney stones? Oh, because when you have excess calcium in the blood, they're going to deposit places, and they're going to deposit in the kidney. Makes sense. Okay. I have one more slide here. I don't know if you have it in yours or not, but I'd like you to look at cirrhosis. We will talk about cirrhosis clearly when we get to gastrointestinal at the end of the semester. But it's important here because, as we talked about, the the liver produces a number of substances which influence flow of fluids in the body. So it's an irreversible end-stage condition in which basically you have scarring of the liver, and such that things aren't flowing in or out of the liver. Generally, it's a result of excess alcohol and or hepatitis, long-term hepatitis, hepatitis C, end-stage hepatitis C, hepatitis B possibly, will cause cirrhosis or scarring as a result of all that inflammation. We haven't learned this yet. Long-term inflammation causes the release of causes an increase in the number of fibroblasts. Fibroblasts are cells that will lay down. They produce scar tissue, and it'll so long-term inflammation as a result of alcohol or hepatitis will cause scarring in the liver, and because of all those fibroblasts in there. As a result of all that scarring, you have an increase in the hydrostatic pressure. That increase in the hydrostatic pressure will cause your heart to have to work harder to push against that. And also you're going to get hepatic vein obstruction, and all that's going to contribute to the increase in the hydrostatic pressure, and likely the person is going to have edema. A decrease in the osmotic pressure, you could think of that as a decrease in oncotic pressure as a result of damage in the kidney. They're not going to have as much albumin, as I talked about, and that's going to decrease the oncotic pressure and cause edema as well. And then also, because secondary to the chronic inflammation of the cirrhosis, you're going to have an increase in the capillary permeability, and therefore you're going to have edema. So cirrhosis is, people with cirrhosis have edema because of those mechanisms. Okay, I'm going to take a quick break, just a brain break here, and I'll come back and talk about acid-base. This is all on those other videos, but I'm going to try to explain it. Maybe I'll say something a little bit differently that enables you to get it a little bit easier. Again, I'm trying to compensate for the fact that I was trying to do the right thing and not cause anybody to be there at school till late and putting them at risk for any kind of weather-related issues. And I may or may not have done the right thing. Sorry. All right, I'll be back.